Hello again, and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain, and I'm here with my brother and co-host, Rohit Gosain, with our mission to bridge the gap between academia and the community to ensure that all our patients receive the best care close to home. We've recently focused on hematologic malignancies. Continuing with the same theme, today we're excited to focus and take a dive into the world of chronic myeloid leukemia, CML.
That's right, Rahul. And to guide us through this complex and rapidly evolving space, we are honored to welcome a world-renowned hematologist, Dr. Jorge Cortes from the Georgia Cancer Center. With Dr. Cortes, we plan to focus on current standard of care treatment options available for CML. Jorge, thank you so much for joining us.
My pleasure. Thank you very much for having me.
All right, even though CML is not the most common malignancy that I get to see in the community, but a lot of patients are living longer with this disease given the advances we've seen in the treatment for CML. And that means we're seeing a lot more of these patients in our community live longer and longer. But even before we dive into our treatment options, Jorge, can you start us off with a brief idea on what's your minimal workup and how do you risk stratify patients with CML in your clinic?
Well, that's a very important question because there's been some changes and I think it's important to discuss them. First, the workup. I do want to do a bone marrow aspiration in all my patients. Can you do a diagnosis of CML without a bone marrow? Yes, you can. You can do a FISH, you can do a PCR, and you can say this is a patient with CML. But the bone marrow provides additional information that I think is valuable in the other part of your question, the stratification. Does the patient have fibrosis in the bone marrow, which sometimes is predictive of outcomes and things like that? I want to do a full cytogenetic analysis because there may be abnormalities in other chromosomes in addition to the Philadelphia chromosome that may impact the outcome of the patients. Even the count of the basophils and blasts and things like that may be a little bit different in the bone marrow than in the peripheral blood. It's usually not radically different, but in those borderline patients, there may be a little bit of a discordance, and you always want to go with the worst of the two. So I do want to do a bone marrow aspiration at diagnosis in all my patients. I think that, and then the stratification, of course, one important component of that is the staging, is chronic accelerated or blast phase. And now we have a little bit of a discordance because now the World Health Organization says there's no accelerated phase. And we all knew about 3 stages, chronic accelerated and blast phase. On the other hand, there's this new entity called the International Consensus Classification that says, yes, there is an accelerated phase. So the consensus classification eliminated the consensus because now we have 2 different ones. The other important stratification is in the chronic phase, the risk stratification. SoCal has been used historically. More and more we're using one that's called ELTS. They're based on the same features, and you can find those calculations online. I think it is useful to do one of those. Just to give you an idea of the risk of the patient. I don't think it's mandatory, but it is helpful.
Thanks for laying that foundation, Jorge. Just to drill a bit more there, I know that you established a bone marrow biopsy to decide whether it's chronic phase, accelerated, or blast phase. Now, is there any utility of doing a bone marrow biopsy during the treatment or at the time of progression, or when do you usually do or repeat bone marrow biopsy, if you do at all?
We definitely don't do bone marrows nearly as frequent as we used to do. I mean, that was the only way we could monitor patients some years ago. So now you mostly do the PCR. The one reason I think a bone marrow or 2 after you start treatment may be useful is there is a subset of patients, maybe 10-15% of patients that as you start the treatment and they start responding to treatment, now you have cells that don't have the Philadelphia chromosome, the normal cells. But again, 10 or 15% of patients now have cells that don't have the Philadelphia chromosome, but have other chromosomal abnormalities. Usually more like MDS type of abnormalities, a trisomy 8, a -5, a -7, these kind of things. They tend to appear early. So I like to do a bone marrow after 1 year of diagnosis, after on treatment, if the patient is doing okay. Maybe again in 2 years. If they haven't appeared in the first year or two, it's very unlikely that they'll appear. In those settings, then the only reason I would do another bone marrow is if the patient's progressing and I need to reassess before I change therapies, or I have the suspicion of a blast phase or something like that. And then you can monitor the patients. Otherwise, you can monitor the patient just with PCR or FISH in a few instances.
With regards to focusing on the treatment algorithm now, starting off with the chronic phase, most common type is what we see is chronic phase in community settings, where the treatment sort of depends, as you talked about, the SOCOL score or ETLS score, comorbidities of the patient, side effects these drugs are going to cause, and also particular mutations. We have first generation imatinib, second generation bosutinib, dasatinib, nilotinib, and in third generation ponatinib, and recently asciminib. Jorge, could you please elaborate? How do you choose between all these treatment options in starting off in your first line and followed by second line?
Yeah, the NCCN, for example, suggests that you do it by the risk stratification, and I'm not such a big fan of that approach, because in all these randomized studies that were done that led to the second generation being approved, comparing it to imatinib, they all showed that even for the low risk patients, there's a benefit for the second generation compared to imatinib. So even if I'm a low risk, yeah, I want that potential benefit. I think some of the other elements that you mentioned may make me choose, maybe more valuable in choosing in my practice. For example, and very important ones, comorbidities. If it's a patient that has a lot of comorbidities and all of that, maybe imatinib is a good choice. I mean, we kind of, because we have second generation and third generation, we kind of feel like imatinib is lesser, but it's a very good drug. And for a patient that has lots of comorbidities and so on, it's a very good drug if you manage it well and whatever. Some patients may need to be changed, but many patients do well on imatinib. And also the goals of the treatment, the patient's goals. Many patients want, from the beginning to focus on eventually stopping therapy and so on. And we know that second generation give you a better chance of being eligible for that, even though not everybody is going to be eligible for that. But the patients who don't really want to focus on that, and that's not their primary, they want fewer side effects and so on, then imatinib is a good choice. So I base it more on those criteria than on the risk classification.
All right, we'll come to the side effect profile for these drugs because that is very important. But in your clinic today with a patient who's otherwise healthy and you're putting a second generation TKI upfront, how much are we buying the benefit when you're comparing this to imatinib versus second generation TKI and potentially stopping this treatment? When you're talking about this for our listeners, can you touch on how much benefit is there in picking up that second generation TKI upfront?
Yeah, and that's part of what I was alluding to on what are the goals for the patient, because survival wise, the survival is the same with imatinib and with second generation TKIs. So for a patient who says, I just want to have the minimum side effects, feel well, have a close to normal life expectancy, imatinib may be a good choice. It's also generic, so it's cheaper. It does have some side effects, but they're, muscle cramps and they're not serious. They may be inconvenient, but they're not serious side effects. The benefit is mostly in the probability of getting to the deeper molecular responses, and there is a big difference. Perhaps you see it best in the nilotinib versus imatinib study because there's 10 years of follow-up. And you see that the probability of getting to meeting criteria for treatment discontinuation, which is a deep molecular response sustained for at least 2 years, it's about 50% with nilotinib. So we need to keep in mind it's only 50%, but it's only about 25 to 30% with imatinib. So you increase your chances by about 20%. So it is a significant difference, but it's not everybody, and it's relatively we need to keep it in proportion. So I think it's important to discuss that with the patient and see how much of that benefit is. But that's the main the main value of the second generation. The second generation, efficacy-wise, they're equivalent. Although we have 10-year data for nilotinib, I think we can expect pretty much the same thing with the others.
Absolutely. And again, you've touched on this already, deep molecular responses. All right, we have NCCN guidelines recommendation on how to monitor these patients, but in your clinic, what does it look like? How are you monitoring these patients when they're on first or second generation TKIs?
I think that's important. In the first year or so, I do every 3 months. I am very adamant at not doing it more frequent than that because there is variability on the test. No matter what wonderful laboratory you use, there is variability on the test. So if you do it more frequent, you're going to see variations that don't tell you much and maybe even more confusing. So I do it every 3 months. Once the patient reaches about a major molecular response and I confirm it at least a couple of times, I move to every 6 months. And that's plenty. If something happens, if I'm changing the dose, if I'm changing TKI or something, I go back again to every 3 months. But otherwise, all my long-term chronic patients, I do every 6 months.
All right, so second generation TKI, better, deeper molecular remission, similar overall survival. Roy touched on this. Now with third generation TKIs, I acknowledge that asciminib is not yet FDA approved, but if this was to get approved, likely we'll see this soon. Are you going to use this upfront for all your patients, or what would that look like?
Well, that's a great question because yeah, I think it is going to be approved. It's likely.
Right.
But so there's two main benefits that I see potentially for asciminib. One is a higher probability of deeper molecular responses. Of course, the data we have is early, so it doesn't really allow you to appreciate the full extent of that benefit. I think it's going to be big against imatinib. The question is how big it's going to be against second generation TKIs. And that's going to be the critical nature. I think initially I'm going to use it on the higher risk patients, on the patients that are more, The second potential benefit, and this may be more valuable, is that so far asciminib seems to be a very clean drug in terms of side effects. It has very few side effects. It has very few arteriocclusive events. It has minimal gastrointestinal toxicity and liver toxicity and all these things. So it may have the benefit of even for patients who cannot reach the discontinuation to be better tolerated for long term. But again, we need to see more long-term data because many of the adverse events that patients complain about, fatigue and memory and all these things, that they're not as evident at the beginning. They're evident when they're on therapy for many years.
Now, whenever these patients are living so many years now, which is a good thing, the question that always comes about is drug holiday, or when is it appropriate to stop these medications? How does that conversation look like, and how do you make that decision in particular?
Well, one important thing is that I think that conversation needs to happen at the time of diagnosis. The patients need to be aware that could be a possibility. Also, we need to make it clear it's not for everybody. Not everybody gets to those criteria, but that it is a possibility because it starts with how how we choose the drug, what drug we use, how we manage the patient, but also the adherence to the therapy. Patients need to understand that being adherent and all that. Some of that is because we need to help them manage any adverse events. Some of that is just them taking the drug. So it's a co-shared responsibility for the two. So it's important that they know that, and if that's important for them. But then we need to then guide them through the therapy, and then the important thing is establish the guidelines. Usually it's deep molecular response sustained for 2 years. There's several studies that have shown that the longer the duration of that deep molecular response, the better the chances of maintaining the response after you stop therapy. I tell the patients, 2 years is the minimum I accept. 5 years is optimal. So some patients want to stop as soon as they meet the criteria. Others say, okay, if I have a better chance, I'll wait. If you know. The other thing is, what is deep molecular response? I prefer MR 4.5. Some guidelines suggest MR4, but then you have more relapses. So yes, more patients are eligible, but more patients relapse. So it's not a good trade-off anyway. So I prefer MR 4.5, and again, ideally sustained for at least 5 years, but at least for 2 years.
Now, this was a patient who's doing well. Now, if the disease was to progress and you plan to switch TKI, the decision to switch therapies can be very challenging. What factors do you think before making that call, and how do you go about this?
Important thing, is this a resistance or is this an intolerance? Granted, many times it's a little bit of both.
Right,
They were intolerant, you have to lower the dose, or they're not responding, but you
right.
cannot go up. So it's a mix of both things. In
Very
those
true.
instances, I consider it more of a resistance, but take into consideration what caused me to lower the doses to then see what I'm going to use next.
Right.
If I had to lower the dose because of pleural effusion on dasatinib, well, I want to use maybe nilotinib or something that has less pleural effusion. So that's part of the definition. Now, the second thing is mutations, and we understand that there are mutations that can guide you towards one TKI or another. But I think there's a couple of things that are important to remember about the mutations. One is, we focus on mutations because that's the one mechanism of resistance we understand the best. But at best, 50% of patients have detectable mutations, and that's by NGS. Most of the time we use just sequencing, and that's about 25% of patients have mutations. And of all the mutations, only a few of them are informative, meaning they can guide you to this TKI or that TKI. Others are, there's not enough data, so you don't know what to do about them. But the other thing is that when you look at data, for example, with ponatinib, the patients that have the worst prognosis, that have the worst response, are the patients without mutations. And that probably makes a little bit of sense. If there's some mutation, well, you understand the TKI that you're using is probably not binding, not inhibiting, so another TKI may work better. If they don't have a mutation, why? Why are they not responding? More recently, we've learned that some patients, and it's not an insignificant number, maybe 15 to even up to 20% of patients, even at the time of diagnosis, have mutations in other genes, ASXL1, TET2, RUNX1, etc. And those patients tend to have a worse prognosis. So I don't do NGS on every patient at diagnosis because it's only 10, 15%. And what are you going to do with that patient at diagnosis? But on a patient that's going through a couple of TKIs, no mutations, and I don't understand why, that's when I do NGS and then see if they have something like that. And then what do you do with those patients? Well, we don't have specific therapies for those patients, but that's probably a patient where you may want to think about a transplant earlier rather than cycling them through the 5 or 6 TKIs just because you have them. They're probably not going to respond as well.
So, well, while we're talking about transplant, I think this is a good segue to at least touch on where we started, different types and risk stratification, be it aggressive stage or now or before called accelerated phase. Jorge, if a patient that you're seeing is an accelerated phase, your approach here?
There's two scenarios. If they have criteria for accelerated phase, or what we call the accelerated phase, depending on what criteria you use at the time of diagnosis, these patients do well with TKIs, particularly, and that's a group that I definitely always do second generation TKIs unless there's really a contraindication.
Yes.
They do well. So I started with a TKI. If a patient progresses to accelerated phase while on therapy with a TKI, I switch TKIs, I do something based on mutations and side effects, etc. But I am thinking transplant on that patient. So I switch them to another TKI while I work them up for a transplant because those patients are not going to do well long term. I may get them into remission But long term, especially if it's a young patient and we're looking at long term outcomes, I would definitely look for a transplant. If they're not eligible for transplant, well then you choose your best TKI. To ideally ponatinib or asciminib would be my choices. Although they've been less studied in those stages, but I definitely would look for those.
Certainly. And if you don't mind touching on macitexin, and when do you usually utilize this in your treatment paradigm?
I don't use it much because nowadays we have many more TKIs.
Right.
But for example, a patient that either has a T315I mutation and is not responding, or is not eligible to ponatinib,
Yeah.
and you already used asciminib, for example, well, that's a good scenario to use omacitaxin. Or the patient that doesn't have mutations and you can't, or while you're working for a transplant. Well, that's another one because it's not the TKI, so maybe that's going to help in those patients that have those mutations in other genes, but not a able mutation. So there are some scenarios where asciminib, we know it's not nearly as good as any of these other drugs, but in these niche indications, it may have value.
Thanks.
All right, before we start to close up, I think important topic to touch on is going to be some of the side effects that we run into, be it first, second, or third generation TKIs. Do you mind touching on some of the common side effects and some clinical pros around these TKIs?
Well, one important one is myelosuppression, because the problem with myelosuppression is that is the one where you have more problems cross intolerance. These patients that have uh, and not the early myelosuppression, but the patients that have been on TKI for a few months and you have particularly thrombocytopenia, that may be very hard to manage. And there's a few things that you can do with that. One is adjust the doses. Sometimes with that, you have to adjust your goals. You may not get to an MR 4.5, but if you can get to a less than 1%, maybe at least an MMR less than 0.1%. Well, that's all you're going to get with that patient, as long as the patient can, you can balance between the thrombocytopenia and the response. We've done studies with the Thrombopac, and it works very well. It's not approved for this indication. If you can somewhat get it for a patient, it works very well, but it's not always easy to do. Other adverse events, pleural effusion with asatinib. Once a patient has a pleural, one time you can adjust doses, things like that, and many times it works. Second time, you have to change because those recurrent pleural effusions are tough. I wouldn't change to bosutinib, although bosutinib itself has a much lower risk of pleural effusions than dasatinib. It probably cross
Yes.
more with dasatinib. So I would go more to a nilotinib, for example, or asciminib, for example, that have very little of the pleural effusion. Gastrointestinal toxicity, imatinib and bosutinib have more. So you try to go to some of the others, but many times these we have to differentiate between the chronic diarrhea than the acute diarrhea that you see with most patients with bosutinib, but it's very transient and manageable. So I always want to manage it and adjust doses and all of that and see, when I start bosutinib, most patients have diarrhea for the first few weeks, but I want to help them through that and see if I can get them, past that. Most patients, they can manage it, and then I can continue. I don't want to discard a drug just without even trying to adjust doses,
Excellent.
manage toxicities, things like that. The biggest problem is arteriocclusive events. Ponatinib certainly causes that, and then nilotinib, dasatinib, much less asciminib, even less bosutinib, and the one that doesn't really cause that is imatinib.
All right, in those settings, are you using prophylactic anticoagulation for a high-risk patient?
We haven't established the optimal management for these patients. I tend to use statins on these patients a lot. The aspirin, I think if the patient has indications for aspirin because of comorbidities and all of that, I certainly use the aspirin. I don't use aspirin just because I'm using ponatinib if the patient has otherwise no risk factors.
Dr. Cortes, initially we were worried to pack everything in about 15 to 20 minutes, but you did such a phenomenal job. And thank you so much for your expertise and covering and reiterating the current standard of care for CML. This discussion has certainly provided a lot of valuable insights for us as community oncologists. So thank you so much. For our listeners, let us go over a quick recap.
In our discussion today, we had a chance to focus on the current standard of care treatment options for CML with Dr. Jorge Cortes from the Georgia Cancer Center. Risk stratifying upfront in CML is critical in selecting the right treatment for our patients. Also, treatment holidays in selected patients or switching to another TKI based on their molecular response is important.
We also had a chance to touch on some common side effects that can come along with these treatment options, including asciminib, which is likely to get approved, given exciting data from ASCO 2024. Thanks for joining us. Stay tuned for more discussions in the latest in hematology and oncology space. We are the Oncology Brothers.